I'm Jay Moran.
I'm Bridget Jaipal Valenza.
I'm Thomas O'Neill White.
I'm Angela Preston.
We need to get together and let our voices be heard.
This is What's Next, a dedicated hour to have important conversations about the issues facing the marginalized and underrepresented communities of Western New York and Southern Ontario.
If we're going to have some real healing, we've got to have space to tell some uncomfortable truth.
What's Next continues our mission to discuss race,
Equity,
And the common concerns of Buffalo's East Side and beyond.
In the suburban area, everywhere, we must work and teach our children.
Welcome to What's Next. Today, we're going to talk about the National Witness Project. It is an evidence-based cancer education and outreach program to reduce cancer stigma and address inequities in knowledge, awareness, access, and early detection among the underserved Black community. We are very fortunate to have the co-founders of the National Witness Project with us today, and that's Dee Johnson and Deborah Irwin. Thanks for joining us.
Thank you for having us.
Glad to be here.
It's outstanding to have you with us here. There is a lot to talk about because the National Witness Project dates back to the 90s, right? Okay, so it's been around for a while, but it has been based in Buffalo since you guys came to Roswell. How many years ago was that?
We came in 2006,
Okay.
and we actually had a witness project here in Buffalo before we came because the witness project site here in Buffalo started during 2000 when we had a grant from CDC to replicate and disseminate the project. And so Dr. Thelma Hurd here at Roswell Park at the time started the Witness Project here. And so when we came here, there was already one waiting for us to work with.
So that made it easier in that regard.
Yeah,
Absolutely.
transition very easy.
But an interesting part of this started in Arkansas. Let's talk about the roots. I'm interested in how both of you kind of came to this point.
So, since she's really the founder, I'm not the founder of the Witness Project, but Dr. Irwin is one of the co-founders,
Okay.
the original co-founders of the Witness Project. I'll let her tell us about her 35-year journey, starting from Arkansas.
Yeah, so we I'm a medical anthropologist and was hired at the University of Arkansas for medical sciences at the new founded cancer center there. It is not an NCI designated cancer center like Roswell is, but small cancer center there, and was intrigued. My mentor and the man that hired me, Dr. Kent Westbrook, was very interested. He's a breast surgeon, and he was so upset because they had so many women with breast cancer that were dying and came in late stages. And then at that time, also nationally, the American Cancer Society with Harold Freeman, Dr. Harold Freeman, put together a study and realized that in the 1988-89 is when they first realized about these disparities and inequities in breast cancer, multiple cancer rates, that African Americans have higher rates than white women. They die and have a higher death rate as well. So trying to look at this and what was going on, and when we looked at screening rates, all of the screening rates were lower. So I got some funding together. I put together some things and did some focus groups. And one of the things that happened, and I just have to talk about Earl, Arkansas, this woman in a focus group stood up and said, "If God wants me to have a mammogram, he'll tell me." So I had to figure out how do I get a message from God?
Get in touch with God. Okay.
Yeah, to address this, and it just pointed out the need for, and as a medical anthropologist, I knew this already, but really pointed out the need for the cultural adaptation of programs, that it can't be a white woman going out and doing stuff. It can't be just the statistics. It can't be a didactic program. It has to be culturally formulated and adapted. It has to include survivors. It had to be. And so we developed it, and I developed it with 5 to 6 African-American breast cancer survivors. And the first time I got them together, I went around and picked them up at their home and brought them to the cancer center, and we visited, and they had never known 4 other women who had survived breast cancer.
Wow.
So we took a break. They're in the bathroom comparing scars and stories and everything. Then they came back and then we talked about, and they really came up with the idea of we need to witness about this. And in the Christian church, this witnessing is about, how Christ and God and the Holy Spirit helps you through problems and gets you through your life and supports you and gives you the direction of where to go. And so they kind of use their stories, and there's no more credible witness in the world than somebody that's actually experienced something. And so the survivors are absolutely the best witnesses. And then we also incorporated it. We did it faith-based. And as the project director we had there, one in Little Rock years ago, said, wherever we go, we have church. So it doesn't have to be in a church or a faith-based place to do the program, but oftentimes it is. And then oftentimes, Dee's branched out. We do it in Buffalo Municipal Housing. Right. We do it everywhere, and everywhere they go, there's kind of hymn and a prayer and some things incorporated so that it's meaningful and the message is credible and people can do it. And so that was the start of it.
Yeah, it's a fascinating element to this. Is just like you said, the bearing witness is really the core of it. It does seem. At the same time, we've talked a little bit about this issue of why, or the reality that when it comes to African Americans, they're social determinants of health. We've heard that topic quite a bit. Let's, if we could, just go through of the realities that you have seen through these years of, why it's happening, both from, whatever case may be. What's preventing better screenings, more screenings? What are the things that are actually, let's try to go through those just a little bit here as we move through our conversation.
Yeah, well, I'm happy to do that, Jake, and thanks again for having me.
Pleasure.
I think the most thing that stands out to me, and Doc, we can kind of elaborate on this both back and forth. The biggest thing that I've heard over my 20-plus year stay at the project is medical mistrust. That's a serious thing, serious discussion in the Black community, which rightfully so.
Right, there's a great deal of history about that.
We have been spending years trying to dispel the medical mistrust, talking about the institution review boards that have been established when it comes to research, those type of things, working on clinical trials, working with other researchers, Dr. Irwin's colleagues and constituents, on trying to dispel medical mistrust within itself. Wouldn't you think that?
Yes, that is certainly true. And it's based on experiences.
Right.
People don't just come out of the womb not trusting a doctor.
Right.
And nobody wants to be sick.
Right.
No one wants to be sick, to have a late-stage breast cancer or any kind of cancer or any of these things. But when the system that they have experienced has shown that they are not trustworthy in certain ways, and that has happened, or they hear about, the culture of our friends and family, et cetera, somebody has a bad experience, something negative happens, then it's like, ooh, I don't know about that. I'm not going to do that. Or maybe that's not right, or maybe this causes cancer, or maybe that, we saw this certainly with COVID too, in terms of the vaccinations and all the other things. But the system, then the other big piece, and Dee, you can elaborate on this some more, is the fact that a lot of the women, particularly when we first started this, certainly, when you're working with individuals that are maybe on Medicaid or limited Medicare or no health insurance or don't have the resources, and until the funding started for covering preventive services, and particularly with the Affordable Care Act, that really enhanced things. But who wants to spend $20 to go do something they really don't want to do,
right,
that might hurt?
Right.
And so there are a lot of personal barriers on that, and system problems with transportation, making the appointment. Where do I go? Is this a trustworthy place to go? Who's going to go with me? I don't know anybody else that's had a mammogram. Nowadays, most women have. We have increased significantly. When we first started the Witness Project, it was like the screening rate was only about 50%.
Okay.
Now we're up to 80
50%
plus.
easy.
But not for other things. So now we're dealing with this with colorectal cancer and lung cancer screening and some other things too.
Yeah, Jay, and I was just going to touch on what Dr. Irwin mentioned was the second big point that stands out to me with regard to your question is access. Women in the Black community have challenges with transportation, even just calling their regular clinician or PCP office to schedule an appointment. It's a challenge, with doing that because we got Nasty Nancy on the other line.
Right.
Right? So
She's in your office too, huh?
yeah, she's in
So
my
it's just
office
my
too, but
office.
we're trying
yeah.
to culturally train that young lady. But yeah, access is a huge challenge to access care, and we're trying to eliminate those issues as well by assisting, like Dr. Irwin said, with completing your paperwork. Because, believe it or not, in 2024, people still can't read. They tell us, and we get the hint, oh, I left my glasses, sweetheart, at home. And then one of our volunteers slide right on by, oh, Miss Jones, we're happy to help you do that. So helping them complete their paperwork with regard to getting scheduled for screening any type, providing transportation, because that's a huge issue, and we all know that. And then, most of these women still have children, so assisting them and kind of providing child care services. And then
Or they have somebody's grandchild.
Or they have somebody's grandchild,
their
correct,
grandchild.
yeah. And then the huge thing that Governor Cuomo and the governor currently, Kathy Hochul, is eliminating that copay. And then facilities opening up specifically for breast screenings nights and weekends, right? Those things really, really assisted with alleviating some of the challenges that we had for access and services.
Interested, as we're talking about things have improved, what is the current status, though? What are some of the numbers we should know about the city of Buffalo and specifically its Black community? Where does it stand right now? Or as recent as the information that you would have, where do things stand right now? Because again, we hear about the social determinants of health; they're not good. But what do you see? What are the numbers you see?
Prior to COVID, we about 80%, and probably higher than that for white women, but at least 80%, 85%.
We're getting screened.
We're getting screened, or had a screening, and maybe not last year. Maybe not every year, but they had been screened at least. And and it's important. Let me just say, it's important that it's supposed to be screened every year, not just every 3 or 5 years. But then COVID hit, and all of a sudden that really dropped. And I think I can't remember exactly the percentage drop, but it was statistically significant. And the American Cancer Society and other organizations were very concerned about what's going to happen, because all of those screenings that were missed meant that many more women that were going to be late stage. But the death rate from breast cancer in Black women is still about 40% higher than white women. And one of the issues is also that Black women are much more likely to have more aggressive type of breast cancer, which is triple negative breast cancer. And so there's...
And what's the root of that? I mean, what do we understand about that reality?
Well, you mean the cause? Or
you said it tends to be more aggressive.
Oh, it's more aggressive. It's oftentimes not picked up initially on a mammogram. And so if women that are at high risk can get MRIs in addition to mammograms, but then when it is diagnosed, it doesn't respond to treatment as well. The triple negative, it's different. It's not responsive to hormone therapy and other things, so it is harder to treat. But we have a lot of survivors of early diagnosis of triple negative breast cancer that are working with the Witness Project right now. We have a lot of witnesses that and members of our team in Buffalo and at the 16 sites nationally who have had and survived triple negative breast cancer, and most of them have been on a clinical trial as well, and they've done very well. So it's not that it's inevitably a death sentence. But if it is found later and they are not treated at a facility, and this is particularly true, it was particularly true probably 10 years ago, but even now, having really knowledgeable surgeons and oncologists that are focused on the specifics of all these different stages and types of cancer is really important for women. And that's another thing that the Witness Project overall and in all of its sites has been able to try to do, is making sure women are not just told, oh, honey, you're too young to have breast cancer.
Oh.
That's an issue. We oftentimes still have some of a woman in her 30s with a lump and are told by her PCP, because at 30 you're not eligible for a mammogram unless you're at high risk.
Okay.
And so they have a lump and they're like, oh, honey, I'm sorry, you're too young to have a mammogram and it'll just go away, you're okay. And the standard of care is that any lump needs to be investigated no matter what age.
Yeah, that's not necessarily
We've
the
had
case.
20 women in their 20s with breast cancer.
Right.
So it's not just a lump that you assume is a cyst and nothing is not cancerous, it's benign. So trying to really teach African American women to be very assertive in their health care and in pursuing their health care. And if they go to a doctor that blows them off like that, or isn't taking them seriously, and or if they have a positive mammogram and they're not sure about the treatment plan, we really recommend a second opinion as well.
Boy, you keep on opening up doors of things I feel like I need to know about. Let's just make sure we understand, though, for anybody who is listening, high risk. Yeah. Let's make sure that
Okay.
we understand what we mean by high risk.
So that's a woman who has a mother or sister that has had breast cancer really at any age, but particularly if they've had it younger. And women who have not had children are at higher risk. Black women are at higher risk. They also, now being black will not necessarily get you a mammogram at 30, but if you have a family history. And now there's also links with other types of cancer in the family, prostate cancer. And of course, if anybody is BRCA1 or 2, which is a standard kind of a genetic test that lots of women with breast cancer have had or choose to have, particularly if they have a sister, aunt, somebody else in the family who has had breast cancer. They need to be very serious about going to a surgeon or oncologist for their that they've got somebody that's looking at any changes in their breasts, et cetera, and or have a PCP that's just really on top of things and knows and can refer them, because they just need to be able to get the referral for a mammogram. Now, some facilities require you to have a prescription for a mammogram. You know, you have to get a thing from a doctor like you do for a lab test or something else. Some do not, and I will say Roswell does not require a script. Yeah. If you are 40 and older, you can get a mammogram. Now, if you're 30, and you will need to go to a doctor that's going to recognize your risk factors and then be able to refer you.
We are talking today with Dee Johnson and Deborah Irwin about the National Witness Project. There's a lot here, as you can, if you've been listening in here to talk about this. You touched upon an element when it comes to the doctor-patient relationship. We talked earlier about the mistrust, the general mistrust. But we've had more than one guest here who has described a scenario, a black woman who's described a scenario with their doctor where the doctor doesn't listen to them. That there is that sense that right off the bat and you can base it on whatever case you want to say, or why that's the case. But we hear that. How do you come? You're you're the boots on the ground person here, Dee. How do you overcome that reality for somebody? Because I mean, I can only imagine what that feels like. We've heard Serena Williams' story about
Right.
her maternity situation.
Right. I don't think you overcome it. I think you just deal with it head on. And
Okay.
what we teach in our 1-hour education programs at the Witness Project is if you don't see eye to eye with your doctor, work with the community navigator that the Witness Project has to assist you with finding another doctor. Not
Does
sure.
that happen with some frequency?
Oh, absolutely. I would say 20%.
Okay.
We've identified over these last 12 months of patients needing PCP referrals because they're not really pleased with the current doctor they have. Those are huge challenges, but we encourage the community at large to seek a different PCP, a like-minded one. We have navigators that can help them do that because access is a big issue for us. And then we have our own medical director who's great, and she's Dr. Julia Devenish. She is a physician over at Community Health Center of Buffalo.
Okay, and so you refer
Absolutely.
people out of the Witness Project?
Absolutely.
Look, maybe I want to hear a little bit more about. So then, how when you came to the National Witness Project was here already before both of you arrived to work with Roswell on this. But these events, these community events, talk to me about how they develop, what they're really like.
So let me just step back and give my point of view in terms of when I first came to the Witness Project. Dr. Irwin and Miss Charlie and Miss Maddie set up this wonderful, wonderful program. So I initially came in as kind of like a business management manager or something like that, and I had never seen a program. Well, for 3 months, I'm looking at all of this data we're collecting from these sites all over the country and talking to all the staff members and team members. So they invited me to a 1-hour presentation. And I get in there and I'm thinking, this is going to be a PowerPoint presentation because I'm, fresh out of school. I'm like, okay, this is going to be a PowerPoint presentation. And oh my God, was I in for a rude awakening. These ladies actually got up and talked about their own personal experiences. And for those Black listeners on this station, know that we don't even do that. We don't talk about our personal life and stuff that happens to you in public specifically.
Right.
So these ladies got up and they were talking about their experience. And I'm a Christian. And so it resonated with me talking, adding God in it and how he brought them to it and how he was going to bring them through it. And, there's significant challenges with, radiation, whatever their experience was in terms of going through this cancer. Because in our community, you say you got cancer, we're like, okay, you're checking out. Yeah, you're leaving,
Right.
You'll be out. We need to make some funeral arrangements and all that good stuff. But these ladies just empowered me so much to want to even come do this work for these last, 15, 20 years I've been on this battlefield. But the storytelling, the narrative of the program was so powerful that you couldn't help but, be engaged and say, okay, if this lady can do it, I can too. I need to get a mammogram. But they crafted Dr. Irwin and Thea and Charlie and Maddie and all the original Witness role models crafted the program in such a way that you either going to be inspired, you're going to be inspired, you're going to be motivated, and when you leave, you're going to be activated, meaning you got to do something. Something's got to happen. You got to get
So
a
you
mammogram.
see that when when these witnesses are standing up and they're talking, they're
Most
telling their
certainly.
stories. You see the other part of the room that they're reacting to this.
Yeah, and I'm sure Debbie can give can expand on this also. We've been in rooms where, and particularly in churches where other women in the audience have had breast cancer, never told anybody, not even their pastor. They were taking off their wigs and testifying that, you know what, I'm a 20-year survivor, and that's incredible.
Wow.
Yes. The other thing is we have lay health advisors that aren't role models. They haven't experienced cancer themselves, but they oftentimes teach the breast self-exam. Now, breast self-examination is not a screening tool.
Right.
And NCI and Cancer, a lot of Coleman still supported it for a while. But anyway, have not necessarily encouraged people to do that. But for younger women, it is all they have. And for other women, one of the things that we have shown and that has been published is that women who do examine their breasts are more likely to also get a mammogram. So for some of the people in the audience, they're either younger or they're just not quite there and ready to have a mammogram, but they start doing the breast exam and they start thinking about it, and then they kind of can maybe be moved as a behavior change mechanism, getting them to think about doing breast self-exam and doing that, and also making sure and asking for an exam by their clinician. A lot of doctors don't give women clinical breast exams anymore, and that's or it's very cursory, and so asking for that. And I just wanted to add another thing in terms of the assertiveness piece. There's also public research publications that have demonstrated that, just for example, for cancer patients, breast cancer patients, black women and white women, a study that showed that if they ask about chemotherapy, they're more likely to get appropriate treatment than if they don't ask. So the being assertive with their doctor is a good step for them in terms of being able to get what they want, even if they don't know what it is they need. But just asking about it, is there anything else I can do? Is there anything else you have? What about chemotherapy? What about this? And then they do. Because one of the things that's happened, and it's not going to happen at a National Cancer Institute designated cancer center like Roswell necessarily, but at many community hospitals and all around the United States, professionals that are not maybe up on the very latest things, et cetera, may not recognize and know exactly what to do, or may not even offer chemotherapy to some women.
Okay, I guess that is an unfortunate but most certainly understandable reality. This is a question, I didn't want to pass this over, but and I'll take you back to those early days. And I think we can say that the National Witness Project is a success based on its expansion, right?
Well, we'd like to think so.
I would like to think so. I mean, 17 different sites. And
We've got a new grant.
Yeah.
We got a new grant with our colleague Rachel Shelton at Columbia University, and it's a 5-year grant to study sustainability.
Okay.
Of the Witness Project.
Did you know though when you started? Did you have a sense that this was going to be successful?
That's an excellent question, Jay.
Yeah.
No.
Did you really know, Debbie?
No, I had no idea. I mean, we were just doing this one program, and we were working on Arkansas, and then we were excited when we branched out to the rest of the state. You know, we were in like 2 counties, and then we branched out and recruited, and then we started. When I started presenting the data and the program at national meetings, people would come up to me and they'd say, well, we want one of those. We want. And one of the first ones was actually in Connecticut, of all things. And I thought, whew, that's a long way from the Delta of Arkansas. Well, that's a kind of a little twist. And so we've done. And then since then, I should just add, we have transcreated it for colorectal cancer screening, and that included men.
Okay.
So we had to start working with black men, and that's been exciting.
Yeah.
And that's a different approach. Yeah. And then we're also, and of course, we also include cervical cancer for women in the program. And now we're looking at working with some colleagues in New York City and New Jersey and here with Mary Reed here at Roswell, looking at developing the Witness Project for black men and women for lung cancer screening.
Okay.
Because their rates are terrible.
I want to also go back then to these sessions that you have.
Okay.
At the end, you said they are activated.
Activated.
Explain activated.
So we used to do pre and post tests, so knowledge in terms of what information did you know when you came, and then take the same test again, and what information you have now. So it should change, right? But we don't do that so often, so much. But just being able to be interactive. Do you remember Debbie talking about that lay health advisor? So that's the person that don't have cancer, but they do have minimum information to provide for general population. We're not, our team members are not experts at all, but we're just trained community health workers that are there to assist the community at large with access and, eliminating any challenges they might have. So once they're activated, we have a community navigator They can, if they need services, any type of help, complete a one-page assessment. And once that one-page assessment, and we have it electronically now, so they can put it on their phone, they can complete that document, and then a navigator will call them, contact them.
Okay.
Hey, Jay, you were at First Pillow Temple on last week. I was following up. You indicated you need help with the following. So,
Okay. All right. So that's how you get things rolling in that
Yes.
regard. And then you find if transportation's needed, you find a way to make that happen.
Yeah, absolutely. And then we host what we call one-stop screening events. So for example, if we have a Saturday event where we have physicians and that kind of thing, and they get a screening, we pick them up, they get on a schedule for that day, and we give them gift cards, anything we could do to encourage them to come on and modify their behavior and get the mammogram.
And I just have to add that when the mobile mammography units first kind of started, we first got one here, et cetera, and everybody thinks, oh, this is great. We're going to pull up, and everybody's going to come on.
Right,
and,
right.
you will build it, and they will come.
Not at all.
Well, D was like, no, we got it. You're going to have to do something about it. So they did. The groups did a few of those, and then nobody showed up. Why is nobody showing up? What's going on? So then she really did, in terms of community organizing and getting a hold of and working with primary care clinics, community health clinics, locations, whether it was Walmart or whatever, and doing the prep work ahead of time to do either a program or do other information to people who had attended or done something else, so that women would show up
Yeah.
to
Right.
begin with, and that we had them there, and then they were being
Yeah,
screened.
those folks that rolled those mobile units out early on had this preconception that, if you build it, they'll come. Not true. You actually have to go out and do some community outreach and engagement. Bring the actual unit to the community. Say, you know what, just come on and check it out, see what it looks like, and then have somebody do a tour of the unit. I'm excited to announce that this is like a little premature and early, but Roswell is going to acquire a mobile mammography unit over the next 6 months.
Okay.
So we'll be the conduit, the
And
witness
you're already
project.
doing the Eddie.
Yeah,
working
we
on
already
the
have
Eddie.
Eddie lung screening
Oh.
mobile unit.
Oh, wow. Okay.
That's rolling around in the community. But the goal is to encourage, like we would do in that same education program, to do the same, implement that model into the community at large with Eddie and all these other mobile units. But people have to have access. And so I think our most biggest success with mobile units were doing the education prior to the mobile coming, bringing the mobile before the day of the screening, introducing the techs, with their, just regular everyday streetwear on, introducing the oncologists and team members, science to the sidewalk, bringing those tools out to the community so they can get acclimated to what's about to come in the next couple weeks in their community. Work
Building
with the-
relationship.
Yeah,
Right.
social capital.
So it's social
Yeah.
health capital.
Yeah,
we talk about
social
it all
health
the
capital.
time.
And I don't want to necessarily get too deep in the weeds on this, but I'm
Okay,
interested in your stories, and both of you will probably have them.
Okay.
How, we can talk about community engagement and building relationships. That's an overview of it. But when I think of our reporters here and the types of nitty-gritty phone calls and doors they have to go knock on to get to where they are. Can you take me just through how some of those things? Where do you start?
Oh, so community engagement, you actually start on the street. So you get a list of people from the programs. This is how we started. We hosted like 72 programs in 1 year. So each program, the average attendees or participants is about 14
Okay.
people. So 14 times 72, you do the math on that. And then we found that, most of those people said, I'm going to go get this mammogram. And they didn't show up. So we're using telephonics. Remember, I talked to you about, the one-page assessment and then the community navigator reaching out to the participant. Well, when we didn't get her, after 3 tries, we just went back to the street. We go, all right, well, we have her address and we'll go knock on her door. So
Okay.
and we did. Boots on the ground, seriously.
Right.
And we trained community health workers that are from that community and that particular block club that were interested in joining our team. They speak the language. They know Miss Jones. She's their neighbor, right? So we trained those folks, and they were able to go onto their porch and say, hey, Miss Jones, you participated in a program at First Pillow Temple, and we called you. We've been calling you, and we didn't get you. How can we help? And then that's the start of a relationship. And then, of course, doing this work, some people are not as nice and friendly.
Really?
Well, and then the other thing is you may find out that Miss Jones' husband had a stroke.
Right. It's a number of things.
And, there's lots of things that
Sure.
happen to people's lives that keep them from doing. But reaching out and telling them that you care
Yeah.
and that you want them, this is important.
Right. And nothing we do at the Witness Project is a one-off. Right. So like Debbie mentioned, if something happened to Miss Jones' husband, well, we're going to have that navigator, community health navigator, reach back out to her. Well, the community health worker went to her door. She indicated that, her husband passed and she's interested in a mammogram, but not right now. So they'll put some information in the system to reach back out to her. And then we follow up and get her. We've known, I think we started in really screening. Roswell didn't have a screening center. So we were actually working with Sheehan, working at Sheehan. So that was what, 2010? 2010.
Yes.
Yeah, around 2010, right? We've had women from 2010. We had a woman, it took us till 2018 for her to get her first mammogram.
Wow. You
Yeah.
didn't stop.
No.
You look like you're pretty determined.
Right. I'm trying to make an impact in our community.
Right.
And the only way to do that is be dogmatic about it. Be kind, nice, and dogmatic.
Persistent.
And persistent. Absolutely.
You did touch upon it, but it's now you're expanded, so men are involved. Let's talk about the difference between men and women, shall we? Especially when it comes
Right.
to this. Well,
We have to have role models.
Yes.
Right.
And our first role model for the colorectal cancer was Bishop Bowman.
Yes.
And he was amazing and a great leader. And we did videos with Bishop and a woman, Veronica, that was working with us and is still working with us.
Yeah.
One of those triple negative breast cancers that survived.
Survivors.
And is at risk for colorectal cancer because her mom had colon cancer. And so anyway, we did the videos and worked with them and got out. And we still, in the programs that we did, we had a grant for the American Cancer Society for this. No, we actually had an NCI grant for colorectal cancer. And we did it in New York City and here. We had a multi-site study, random program, to try to see what we could do. And we didn't have as many men participate as we had women, which is the norm. We didn't. It was pretty effective, and we did have good responses from those men. But it is harder. It is much harder to get men to go to a doctor.
I'm not totally surprised about that.
No. Whether white, black, green, purple, the men do not want to go to the doctor, and the preventive care piece is not. They're not accustomed to, like women are, at least. For most of their life, they have to go for a Pap test, and they have to go in order to get birth control and various things.
Sure.
So they're used to doing some kind of preventive services, even if they don't like it. But men are not as attuned to that, and they think they're, immortal, and so they don't want to be taught. They're afraid they're going to go in and something's going to be wrong, and they're also concerned that. They'll have to change something else in their behavior because they're going to ask them about other things, whether it's tobacco use or how much they're eating or their cholesterol or something else. So it's a challenge. But we have some good role models for it and for the program that we have had, and we're able to, increase screening some.
You did say, black, green, whatever, it doesn't matter. But at the same time, what about the numbers for black men?
Oh, yes, the colorectal cancer, well, Chadwick Boseman's kind of the poster child, I guess, for young, black, healthy man getting colon cancer and dying from it. Really sad, but the proportion of younger age colon cancers are higher in black people, men and women, but are higher, particularly in black men. And they're also the rates of death from colon cancer are higher in African Americans than they are in whites.
What about from a community engagement perspective? Is the approach maybe a little different when you're
Oh, absolutely.
dealing with men?
We had to go get some heavy hitters to approach the black men in the community. We went in, like Dr. Irwin said, got Bishop Bowman to help us talk to and advocate for black men in our community.
Y'all
and
were
help-
recruiting at McDonald's.
Yeah, we were at McDonald's, everywhere.
Coffee
You
group.
went to McDonald's?
Coffee
We
group
Did.
McDonald's.
Coffee Group McDonald's. It's a bunch of gentlemen hang out over there on Grider.
Oh, okay.
Grider and Delavan, and it's gentlemen, and so we had to take Bishop Bowman and some.
You
other
went
people
right
over.
in there?
Yes.
And
Yes.
intervened,
Yes.
for lack of a better term.
Yes.
And what was
Yes.
the initial response?
So, they were very receptive.
Okay.
Once you have someone, a survivor, talking about it and the challenges of, the screening or I think what resonates with folks is when these survivors say cancer and then they're looking and they look, like a picture of health and,
Yeah, and with colon cancer, we were kind of pressing for colonoscopy.
right.
Well, colonoscopy is not a real popular test.
I think I've heard
It's
that, yeah.
it's a real intervention. It's invasive.
No doubt.
So people don't really want to do that. We have better luck with people doing a fit
Fit
test,
test,
the stool sample
Right.
test. But with the colonoscopy, one of the things we did with the program was having witnesses who had had a colonoscopy just to talk about the colonoscopy. It was clean. They didn't have colon cancer, but they had had a colonoscopy, and that was very important to help people understand how is it and what is it really like and how bad is the prep and various things on that. But we still don't have a real positive, in terms of statistically positive outcomes from outreach to increase colonoscopy. We're getting it, and we're doing it, and we're doing it with Witness Cares some as well. But people would prefer just the stool test or the Cologuard or something else, not doing the invasive. And the colonoscopy is so important because if you do have a polyp, you can't tell if you have a polyp from Cologuard or doing
Right.
the FIT test. But if you have the colonoscopy and you have a polyp, then they can remove it, and you never get the cancer in the first place. So personally, I've had the first time I had a colonoscopy at like 51. It was right when I got here, and I had polyps, and so I had to go back every 5 years instead of every 10. And who knows? That may have saved my life, but up to this point anyway.
You said you bring in the heavy hitter. What if you don't mind, share a little bit maybe what you hear from the bishop or other survivors. Begin focusing more on the males here. What are those seem to be the most powerful stories that hit?
Yeah, so we don't tell their stories, but I mean their stories being told to the people that they're in front of,
Right.
I think is significant and resonates with the other gentlemen. I mean, just for example, I'll give an example of the McDonald's on Grider. It just appeared when the survivor opened their mouth to talk about, their bout with colorectal cancer. The gentleman seemed to be attuned, wow, I didn't know that, and then we teach our survivors or witness role models to tell their stories in a crafted way with Christ at the center, but they also are trained about the risk factors and the barriers, etc. So to me, you got a knockout, right? I'm empowering, telling my story if I were a survivor, about how God brought me to it, he brought me through it, and then talking about the risk factors, what do you need to do from this point, And then the most crucial piece of our model is once they're activated, we actually have somebody there to help them, right?
Right.
To actually decide, if they want the fit test and or if they want the gold standard to go and get the colonoscopy. So it's telephonics and then it's boots on the ground, and they are one and the same. They go together, if that makes sense.
Yeah, well, it totally makes sense.
Yeah.
Absolutely. We've been really focusing on the idea that here in Buffalo, where the Black community is, so prominent, and of course, and the determinants of health are generally so low. But does it matter? I mean, do white men, white women get involved? I mean, do you end up recruiting? I mean, I assume to be qualified.
Yeah,
Yeah.
well, my
does that
mantra at
work?
the project is we don't have a respectable person. Anybody that wants to help us do this work and come out on this battlefield, you are welcome to
Okay.
the National Witness Project. I mean, our target is Black people, for Black people, by Black people, to Black people. But we have Dr. Irwin. She's not white. I don't know if the listeners could tell. I mean, she's not Black. I don't know if the listeners could tell.
That was a Freudian slip.
I mean, we're from Arkansas. You can tell by our dialect that we're not from, upstate New York. But we don't have a respectable person. We really are trying to eradicate, all of these cancers, get people empowered, motivated, encouraged to, do their preventive screenings.
Right, and Witness Cares is totally focused on Medicaid, so it's everybody.
Right.
It's everybody.
Yeah, well, that's a great opportunity to transition to Witness Cares, which is a company that the two of you founded as well, and it kind of plays off the National Witness Project, but it also, I think, it assists. It helps people, with access and in terms of covering costs and things along those lines. Explain how that works.
So, well, Dee is the backbone. She is the entrepreneur. She is the person that has been pushing me and everybody because Jay, one of the things that we have said for years and years. So we would get grants, we get funding, we get support from Roswell, we do whatever, and encourage our other sites around the U.S. for National Witness Project to be able to continue doing work, because we have a lot of volunteers, but we need some staff too,
Right.
and you need to be able to help people in the community, especially the women and men that work with us on National Witness Project. We need support for them to do the work that they do, even if it is partly volunteer, but to be able to do it. And certainly if we're collecting data, we need it. So we've had grants, we've had contracts. Yes, Dee got really good at getting contracts for National Witness Project doing the community work. During the DISRIP, you can talk about all that stuff.
You're in
Multiple
the
things.
building of a nonprofit organization. Don't let anybody know that we have somebody who can go out and get grants.
I
and
know.
contracts, okay?
Really, she can raise the money. So, in doing that, and so we're like, well, if we could do that, and so we were invited to participate because we had the grant, the study that we were doing on colorectal cancer, and they were looking for people doing intervention, and it was actually influenced by Congress that said we put all this money into NIH and we want to see what happened. We want it to be more widely disseminated. We do this research on interventions, we find out what works, and then it goes into a journal article or it goes into a book and it goes on somebody's shelf, or it may get disseminated and utilized like Witness Project has, or it may not. And they wanted more dissemination, implementation
Okay.
of the things that work. So we said, how do we take the things that work? And we invited this training to figure out how do we make it commercialized? How do we commercialize this? How do we get somebody to pay for this? Who's going to pay for it?
Right.
How are we going to do this?
It was
And-
so challenging.
Oh,
Jay.
it was a
my God.
lot of work.
Oh, my
I can't even
God.
imagine.
I am too old to be an entrepreneur.
It was so
I'm
challenging.
too old to even think about
How
it.
long was that course? 6 months?
the sprint
Uh-huh.
the sprint was only about 4 months, but it was very intense and we had to do a lot of work. But we did recognize that in getting out of the building and talking to people, there was a need, particularly the timing of it was crucial. The Affordable Care Plan opened up a lot of opportunity by the insurance the health plans, but also for a business like ours wanting to start, because all of a sudden there was federal and state incentives for health plans to do more.
Right.
There's the quality measures. There's trying to increase screening. They took away all the preventive services, didn't have co-pays anymore. A lot of things happened. And in doing that, though, we still saw that the Medicaid population was still not accessing services for the same reasons the Witness Project was trying to reach
Right.
the
Right.
people
Right.
we were reaching.
Right.
The social determinants of health were
Right.
still interfering with Medicaid access.
Right.
And so we started out, and at the time, we were with a plan that's no longer here in Buffalo, but we did a pilot study and we got NCI funding. They fund these STTR and SBR, these
Small business
small business
innovation
innovation research
Right.
grants to see if an idea can be successful, if you can commercialize it. So we got one of those grants and partnered with this health plan and found out that, yes, we could actually raise their quality measures over a year's time with us practicing. And we had to kind of convert part of the Witness Project model into something that could be done primarily telephonically, some maybe in person, but to provide access and connect the dots and connect people with their PCPs. And we started out just doing it for colonoscopy and colorectal cancer screening. Then we found out in doing a second I-Core training that we really needed to broaden out and add more services. So now we, with Witness Cares, we have contracts with health plans to provide navigation, and Dee can elaborate on this, for the wellness visit, seeing your primary care provider once a year, getting mammograms, getting Pap tests. We're going to be working more, and we're still working on the colorectal cancer screening,
Okay.
FIT test or colonoscopy. And then we added chlamydia,
Yeah.
and then we may be adding some other things. But go ahead. This is her baby. This is her
It is,
thing.
and well, she helped develop it, our baby. I just knew all the time all the work that Dr. Irwin had done, her and a co-founder, and then the 7 original Witness role models, that we did have a minimum viable product. I just didn't know who was going to pay for it. And then being in the room with our coach, Edmund Pendleton. He just had
He's
us.
at Maryland, University of
he's-
Maryland.
Yeah, University of Maryland. He was an excellent instructor in terms of trying to get us to think outside of the box and then get outside and talk with people. We actually had to do 100 interviews with people in the industry during COVID.
Oh, it was horrible.
And I was like,
We were supposed to be doing personal
Yeah,
interviews
right,
in person.
in person.
And of course, that couldn't happen. I kept thinking, they're going to stop this. They're going to let us take a break here. We
and
had
they never
to keep
did.
going.
They never did. They didn't stop. We had to keep going.
And
I had to be
health plans
creative.
and providers were busy with a lot of things
right.
besides wanting to talk to us.
Right, right. But we pulled it off, and
persevered.
we did, and we developed our minimum viable product, and like Dr. Irwin said, in terms of our scope of work, which is telephonic and some in person, using some of that Witness Project framework, tweaking it a bit. And I think for the most part, we've had some minimum success. We've had our challenges as a company, just like everybody else.
Right. But is it fair to say that, I don't want to disparage health insurance companies, but I'll just say it like this: if there weren't results, they wouldn't be funding this. They wouldn't make this an
Right,
opportunity.
that's
right?
very fair to say.
And they
Yeah.
have resources.
Yeah.
Right.
We all know that they do have, and they're actually quite interested. The folks that we have worked with are very interested in increasing screening. They know that's
It's going to save
their
money in
mission.
the long run, and
Yes.
of course, lives.
Yes,
Right,
it is
yeah.
going to save money in the
Yeah.
long
And
run.
lives.
And
Right.
it saves lives, and it's what needs to happen.
Yeah.
And what everybody needs, and outsourcing it to us is the best way for them to do that. It's very cost effective, I think, for them to outsource both the knowledge, the
Social
connections, the
capital.
social health capital, the ability for people to do the motivational interviewing and all the things that we do. on the company end of things to increase screening and to get people engaged, and they're appreciative. And it also increases the value of the health plan to the individual, because we call and say, we're calling for your health insurer, and they really want you to get these things done, and we're, trying to help you access the services that is your due, that is being paid for and is right there on the table. Don't leave it on the table, and get the screenings and save your life and for your family and everybody else. And so it's a win-win for everybody.
Well, believe it or not, we are out of time. Can you believe you weren't just ripped through an hour with us here, huh?
I cannot believe it. It's been great.
It has been great. Appreciate the many different perspectives we've come at this topic with, and thank you for your work, and thanks for being with us, Dee Johnson, and also Deborah Irwin, Dr. Deborah Irwin. Thank you very much for joining us on What's Next.
Thank you.
Thank you
It's
for
been a
having
pleasure.
This is What's Next on WBFO and WBFO HD1 Buffalo, WOLN Olean, and WUBJ Jamestown, your NPR station.